On this episode of Peak, Phantom Eye Syndrome, Musical Ear Syndrome, and Other Medical Phantoms. William Porterfield was an esteemed Scottish physician. He was president of the Royal College of Physicians of Edinburgh and published pioneering works on the physiology and function of the eye in 1737. Many of his theorems on optics stood the test of time and are still referenced to this day. But William had a medical problem of his own that he couldn't treat or entirely explain. For many years, William felt pain and itching in one of his legs. The strange thing was that very leg was gone, having been amputated when William was just a boy. William's sensations were so specific that he could discern whether the pain and itching was in the ankle, heel, or individual toes of his missing leg. This phenomenon was later termed phantom limb syndrome. People suffering from phantom limb syndrome can feel painful sensations, such as shooting or stabbing pains, burning, tingling, electric shocks, and immobilizing cramps. They may also feel non-painful sensations, including movement and gestures, such as wiggling toes, opening and closing a hand, fingernails digging into the palm, the feeling of being touched on the skin, external pressure, vibration, temperature, and itching, all in a limb that isn't there anymore. Some patients report being able to control the movement and gestures, for example, consciously wiggling toes they no longer possess. 80 to 100% of amputees experience phantom limb syndrome. A large number of cases resolve within 6 months to 2 years after amputation. But for some patients, like Dr. William Porterfield, they can last for decades. In the first autobiographical account of phantom limb pain, William Porterfield wrote, "These itchings have sometimes been so strong and lively that in spite of all my reason and philosophy, I could scarce forbear attempting to scratch the part, though I well knew there was nothing there in the place where I felt the itching." Impressively, for a physician practicing in the early 1700s, William's theory about his own condition was sound. He wrote, "Therefore, when the nervous fibers in the stump are affected in the same manner as they used to be by objects acting on their extremities in the toes, heel, or ankle, the same notice or information must be carried to the mind, and the mind must have the same sensation and form the same judgment concerning it." Dr. Porterfield was correct in thinking his malady involved nerve fibers and information being interpreted by his brain, but he still had a lot of unanswered questions and no means of treatment. Sadly, this is still true today, with doctors still debating the exact cause and treatment approaches being relatively ineffective. As to the cause of the condition, the two leading theories are: 1. Phantom limb syndrome could be the effect of neuroplasticity, a process where the nervous system makes changes to itself in response to an alteration in the body's structure or function. In other words, the central nervous system, i.e. the brain and spinal cord, could be trying to interpret the new information sent by the severed and remaining nerves and could be rewiring its system to adapt. Another theory is that phantom limb syndrome is the result of damaged nerves sending confusing signals to the central nervous system, which may cause the central nervous system to initiate movements or interpret the unusual signals as pain or sensations. Because the mechanisms of phantom limb syndrome are still mostly unclear, treatment is tough. Pharmacological treatments include antidepressants, anti-seizure medications, opioids, NSAIDs, and lidocaine injections. Other treatments include electrical stimulation of nerves in the spinal cord, vibration therapy, and biofeedback. One unconventional treatment that has proven effective for some patients is the mirror box. In this therapy, the patient inserts their opposite intact limb into the box, which displays a mirror image, the missing limb seemingly reborn. The patient then looks at their missing limb and moves, scratches, and unclenches their healthy limb as if it were the phantom limb, apparently relieving their phantom pain and sensations. Perhaps one of the strangest things about phantom limb syndrome is that it doesn't just occur in limbs. Phantom pain and sensations can also occur after the extraction of teeth and the surgical removal of genitals, breasts, parts of the face, and, as we'll discuss further, the eyes. Phantom eye syndrome. Studies show that 50% of patients who have experienced enucleation, a fancy word for eye removal, experience some form of phantom eye syndrome. Like phantom limb syndrome, patients experience pain and/or sensation. Pain varies in frequency and intensity among patients and has been described as cutting, penetrating, gnawing, radiating, zapping, shooting, burning, and stinging. Non-pain sensations include itching around the eye, the feeling of opening and closing the eye, and the feeling of eyelids that are no longer present. Eerily, patients with phantom eye syndrome also experience visual hallucinations called phantom vision. Yes, they see from an eye that isn't there anymore. Most patients experience elementary visual hallucinations, such as spots, lines, points of white or colored light, kaleidoscopic and geometric shapes, and shadows outside the visual field. Patients with one intact eye often see these simple spots and shapes as an overlay on the vision they see with their intact eye, kind of like a filter applied to video footage. The images can be constant, flashing, or moving. Other patients suffer from more complex visual hallucinations, such as faces, scenes, structures, and intricate objects. Sometimes the hallucinations are related to past experiences. Other reported issues include the feeling of seeing with two intact eyes, an extreme sensitivity to light in the missing eye, and irritation in the missing eye that causes problems focusing with the intact eye. According to one study, 20% of patients found the hallucinations to be disturbing, and 20% found them to be pleasurable. Certain conditions increase the likelihood of hallucinations, including darkness, stress and fatigue, and closing the intact eye. 30 to 50% of phantom eye syndrome patients experience visual hallucinations, though researchers suspect that number may actually be higher. Many patients are afraid to report their hallucinations, thinking they are a symptom of mental illness rather than a natural result of their condition. A majority of those experiencing hallucinations keep them secret from friends and family. But these hallucinations may seem mild compared to the often terrifying visions of patients suffering from our next medical malady. Charles Bonnet Syndrome, also called visual release hallucinations, is a condition experienced by people who have become partially or totally blind but still have both eyes. The syndrome was first documented by its namesake, Swiss scientist Charles Bonnet, in 1760. Bonnet's 89-year-old grandfather, Charles Lalande, an intelligent and articulate former magistrate, had suffered near total vision loss after cataract surgery. Not long after losing his sight, Lalande began experiencing complex visual hallucinations, including realistic images of women, men, animals, buildings, scaffolds, carriages, and physically impossible circumstances. The visions varied in size, shape, motion, and location. A blue handkerchief floated in midair. Butterflies flitted about before him. During a visit from his granddaughters, Lalande asked, "Who are these handsome young men with you?" His granddaughters laughed and said, "Grandpapa, what young men?" And the two gentlemen standing with his granddaughters instantly disappeared. Another day, Lalande saw a man in a robe smoking a pipe. He realized it was himself. That was the only person he ever recognized in his hallucinations. The visions never made a sound, gave off a smell, or came into contact with him, and he was always aware they were not real. Knowing he was of sound mind, Charles Lalande dictated his experiences and had 4 witnesses sign the document, one of whom was his grandson, Charles Bonnet, to verify he was not mentally ill. Charles Bonnet wrote about his grandfather's experiences, first bringing them to the attention of the medical community. Interestingly, Charles Bonnet himself suffered from an unknown ailment in his 20s, and by his 40s was completely visually impaired and began seeing the hallucinations himself. As with phantom eye syndrome, the visual hallucinations of Charles Bonnet syndrome can be simple or complex. Simple hallucinations include flashes of light, basic shapes, and branching or grid-like patterns. Complex hallucinations, like the ones Charles Bonnet and his grandfather experienced, are typically detailed and vivid. Visions of people, animals, flowers, trees, vehicles, buildings, and more. Many patients experience Lilliputian hallucinations, in which the objects in the vision are miniature-sized. Unnaturally small people, tiny animals, 6-inch tall buildings, etc. Acclaimed neurologist Dr. Oliver Sacks described a 95-year-old patient named Rosalie, who had been completely blind from macular degeneration for 5 years. Rosalie described her visions as silent movies. She often saw pink and blue squares going from the floor to the ceiling, adults and children in colorful Eastern dress walking up and down the stairs. snow falling, and a horse with a harness dragging the snow away. Cats and dogs walking toward her and stopping just out of reach. Regularly, she'd see a man who turned to her and smiled, with huge long teeth on one side of his mouth. According to Dr. Sachs, faces, often deformed faces, are one of the most common hallucinations of Charles Bonnet Syndrome. This is because the fusiform gyrus, an area of the temporal and occipital lobes of the brain, helps us recognize and process faces. The anterior part of the gyrus specifically recognizes and processes the images of eyes and teeth. The loss of visual input to this part of the brain is likely causing spontaneous discharge of neurons and periodically increasing excitability of these regions, triggering hallucinations. Areas that process images of eyes and teeth could create visions of people with unnatural and likely terrifying eyes and teeth. Other overexcited areas of the brain generate the hallucinations of animals, buildings, etc. In some patients, the affected areas of the brain lie close to the amygdala, a part of the brain that processes emotional responses. This may explain why some Charles Bonnet patients have an emotional connection to their hallucinations, and some do not. Dr. Sachs described another patient who experienced visions of a man in a striped shirt approaching her, then splitting into 6 versions of himself, walking ever closer, and merging back together. She would also see a teenage boy on the hood of her car as her husband drove. The boy would move gracefully along the hood each time the vehicle turned. Then suddenly he would leap upward into the sky and disappear. Unfortunately, the strange, unsettling nature of Charles Bonnet hallucinations and the lack of public awareness of the condition causes many sufferers to keep their visions a secret from family and friends, and even their doctors. A recent study showed that only 9% of people experiencing Charles Bonnet syndrome sought medical advice. And what's even more unfortunate, many doctors are not aware of the condition and don't educate and inform patients as they should. Many elderly patients are mistakenly thought to have dementia or Alzheimer's by caregivers. This can be frustrating and disheartening for patients. Charles Bonnet syndrome can affect people of all ages who experience vision loss, but is seen most often in geriatric patients due to the increased incidence of eye disease. A few cases of children with the condition have been documented. In one study, the 2 children, both suffering from cone rod dystrophy, experienced vivid, complex hallucinations of people, faces, wolves, snowballs, ballerinas, flashing lights, and colored balls. It's important to note that people who have been visually impaired from birth do not experience Charles Bonnet syndrome. Interestingly, one of the most effective ways of treating Charles Bonnet syndrome is maximizing the patient's remaining vision. This can be done through corrective measures such as cataract surgery or laser treatment for diabetic retinopathy, or with contact lenses, special glasses, tinted sunglasses, and night lights, since many hallucinations occur during evening hours in low light. Though pharmacological therapy has not proven effective, patients are sometimes given SSRIs, anticonvulsants, antipsychotics, and anti-anxiety medications. Another effective therapy is counseling patients on taking actions to prevent or mitigate visions, such as improving lighting conditions, blinking during a vision, speaking to or walking toward hallucinations, engaging in contact with another person, or concentrating on something important to them. Music can also be a comfort, but not for our next group of phantom sufferers who hear music that isn't there and won't stop. Musical ear syndrome. Also called musical hallucinosis, auditory Charles Bonnet syndrome, or Oliver Sacks syndrome, musical ear syndrome is a condition experienced by people with acquired hearing loss, either partial or total. Like visual hallucinations, the auditory hallucinations can be simple, such as repeating notes or tones, or complex, such as songs performed by a whole orchestra, pop songs from the radio, religious hymns, Christmas carols, or unaccompanied human singing. This isn't like getting bop stuck in your head for 3 weeks. These songs are perceived as real sound, either emanating from within the patient's own head or from their environment. When these auditory hallucinations first begin, patients often think they are hearing music played or sung by family members or neighbors. But within days, they realize the music is coming from their own head. Most auditory hallucinations are songs and melodies the patient is already familiar with, but some patients hear totally original tunes. German composer Robert Schumann was said to have drawn inspiration from the complete symphonies he heard in his head. Later in life, he was plagued by the repetition of an A5 note sounding over and over in his ears. Like Schumann, some patients are tormented by the repetition and continuous nature of the music, which can play all night long for some people. Other patients have a more pleasant and nostalgic experience. Like the other phantom conditions we've discussed, researchers suspect that musical ear syndrome is the result of the release phenomenon. In other words, hearing loss in a patient reduces the normal auditory stimuli to certain parts of the brain, and as a result, spontaneous neuron firing occurs, increasing excitability in those parts of the brain, resulting in musical hallucinations. The fact that most patients hear music that is familiar to them and typically from their past indicates to researchers that the condition involves the hippocampus, a part of the brain that deals with memory. Although musical ear syndrome is not age-specific, a majority of the patients are elderly due to the prevalence of acquired hearing loss in that population. Non-pharmacological treatments have proven most effective. Like visual Bonnets, patients can be given corrective devices, such as cochlear implants and hearing aids to improve their hearing, thus increasing sensory input to the brain and reducing instances of hallucinations. For less severe cases, patients can use mental techniques to try and block the sound. Others find success by playing different songs aloud in their home. I know, sounds counterproductive, doesn't it? To conclude this video, I'd like to play a song by Karl at White Bat Audio. As you listen, ask yourself, am I really playing this music, or is it all in your head?